All right. With it being the top of the hour, I think we can start. First, I want to thank everyone for joining us today. Today, we're going to be presenting our webinar on SIPs and tricks, integrating pharmacogenomic therapeutic drug monitoring and precision medicine in solid organ transplant patients. My name is Adley Lemke. I'm a transplant pharmacist that works at the Mayo Clinic. My pronouns are he, him. And I'm joined today with Dr. Melton, who's another one of the transplant pharmacists working with me at the Mayo Clinic. Next slide, please, Tanner. Today, we have a packed agenda. Our learning objectives include looking at the benefits of pharmacogenomic testing in non-liver solid organ transplant patients. We're going to discuss some implementation strategies for incorporating pharmacogenomic testing into routine clinical practice. We're going to identify immunosuppression drugs with clinically significant pharmacogenomic recommendations. And then we're going to practice application with a clinical case. Next slide, please. With that, I want you to all meet Jonathan. Jonathan is post-operative day 1 from lung transplant, and it's time to start tacrolimus, azathioprine, prednisone, valganciclovir, trimethoprim sulfamethoxazole, posaconazole, and rosuvastatin, and pantoprazole. We happen to have a pharmacogenomic panel resulted for him already, and I've highlighted the phenotypes of significance, which include CYP2B6, 2D6, and CYP3A5, for which he's a normal metabolizer. The big question on everyone's mind is, do we need to adjust our approach to dosing our routine post-transplant medications? Next slide, please. To get into that, we're going to jump into some background information. And with that, I'd like to hand the presentation over to Dr. Melton.
Thank you, Dr. Lemke. So as we talk about pharmacogenomics, it's always good just to have good background discussion, make sure we're all on the same page, using similar definitions and kind of a similar understanding as we go forward. So the kind of general question was pharmacogenomics. A good way to think about it is essentially genetic influence in drug response. So as pharmacists, we tend to think about what's going to impact our medications and how their efficacy unveils themselves with our patients. So things we'll normally think about is a patient's age, their weight, their sex or gender, other organ function, and even how other medications can interact with each other or with themselves to then lead to different changes in medication efficacy. And then the new part we're introducing today is the genetic factor. And a way to think about this is just a drug interaction that we've had since birth, though while we may not always incorporate it when we think about other medications with new data, new testing, this is something that we're being able to introduce a little bit more and see what that role plays into drug efficacy. And right off the bat, it has been shown to decrease the risk of adverse reactions by incorporating pharmacogenomic information into our individualization approaches for patients, and as well as increasing the efficacy of specific drug regimens where this is particularly important. And with that, we'll hand it right back over, and we'll be doing some flip-flop throughout the presentation.
Thank you. So I'm here to convince you on who to test and when to test. Well, known benefits for pharmacogenetic testing has been shown in folks with polypharmacy, patients with high comorbidity burden, vulnerability, those with numerous allergies and intolerances, and folks with numerous drug interactions. All of those factors reflect our transplant patient population. And indeed, especially with vulnerability and frailty, an adverse medication reaction that could have been prevented with a pharmacogenomic test can have a significant impact on their overall morbidity and mortality. So click here, Tanner. The key then to introduce these pharmacogenomic tests and use them in clinical practice is to test prior to transplant. At the point of transplant, we're going to be having the greatest shift in new medications prescribed. We're going to be setting that journey going forward. And additionally, there's some uncertainty of if there's blood given in the OR or the new donor organ, what DNA would be reflected, because that can mix together, and whose genetic code are we looking at in the liver. Next click, please. Overall, I would argue that pharmacogenomics offers high value to solid organ transplant recipients, and that's really our key take-home point for today. Next slide, please.
As we briefly mentioned at the top of the presentation and our objectives, the exception is going to be for the patients who have received a liver transplant. And liver transplant recipients are the exception to this rule to where we would not perform pharmacogenomics normally, because the way we normally get our samples is through recipient whole blood or saliva. And in the post-transplant setting with the new liver, there could be a cytochrome P450 mismatch with the presentation of CYP enzymes across the other tissues, particularly in the GI tract. So when we're looking at a patient who their whole blood and saliva from pre-transplant, that isn't necessarily going to be reflective of what we see in the post-transplant setting, as well as if we try to collect it at the time of transplant, there are further confounders, as Adley mentioned, of other blood, but also this new donor and not knowing what we're interpreting, we can get erroneous results if it's a post-transplant pharmacogenomic panel. So it leads to a lot of inaccuracies and inabilities to properly assess. That being said, though, there are some pharmacogenomic tests that we can still do post-liver transplant, and those are specifically for those instances where it's a pharmacogenomic test for an extrahepatic gene-drug interaction. So the main ones I would think about are the glucose-6-phosphate dehydrogenase enzyme expression, and then human leukocyte antigen genes are two very common ones that we would see in our transplant population that we can still rely on in the post-liver transplant setting.
Now, following transplant, all of us are very familiar with risk management. And what we're looking at is as we increase immunosuppression after transplant, we're taking that rejection risk that we worry about in the post-transplant setting and decreasing it. However, we have to balance that with toxicity, infections, and cancer from our immunosuppression agents. And so really what we're looking for is a targeted sweet spot, an individual balance for each individual patient that says, this is where those two balancing acts even out. And that's what we're aiming for in terms of net immunosuppression to prevent rejection after transplant. I would argue that pharmacogenomics adds in an extra level of individualization benefit where we can get a little bit better of an idea of where that target is for the person in front of us so that we can dose medications appropriately and avoid those toxicities associated with medications. Next slide. Now we're going to start talking about how to operationalize pharmacogenomic testing into clinical practice. And to do that, we're going to share with you our example of what we've built into our transplant practice. Next slide.
So noted pharmacogenomic barriers and obstacles that are documented throughout literature and just in others' experiences are the four we have shown here. So evidence, evidence-related barriers can be the view that more trials are needed to understand pharmacogenomic guided dosing and how it may improve outcomes, looking at the cost effectiveness of these genomic panels, and then just looking at how many more medications we can find that have actionable pharmacogenomics, getting stakeholder buy-in. From the stakeholder perspective, there's really kind of three groups that have been brought up. So the patients really thinking, how are they going to receive this or interpret the data, or just how that might impact their own patient care or clinical care moving forward. From the physician, advanced practice providers, and pharmacists, the view of how do we actually use this towards our clinical decision-making, who does what role, and just general implementation into our clinical practice and systems. From a testing perspective, is it going to be sequencing versus genotyping? From the lab side of things, if there's no standardized set of genes to test, how do we know what we're going to test for, what to collect? And then looking at a system approach, is this going to be presented more as a research situation or for the use of precision medicine, which is what we're more so focusing on today. And then lastly, using those results, kind of like I mentioned briefly on the stakeholders, as well as how do we start to standardize our recommendations, which we have resources that have helped with that. How do you integrate it into a medical record so that others can easily see it? And then raising more awareness of intentionality when we're using a non-standard dose that might not be what we would view as normal FDA dosing, but it takes into account these genomic factors. And then when it would be appropriate to have formulary and therapeutic interchange. So I'll hand this back off to Adley, but we'll go through kind of each of these subgroups and how we've approached this at Mayo Clinic and how we overcome some of these hurdles over time.
All right, so the first step is reviewing what evidence is available to gain stakeholder buy-in. So I would start by showing this study from Zhao and colleagues that looked at the proportion of commonly prescribed medications that are metabolized through common CYP pathways and where we have pharmacogenomic testing available. And what they found were those CYP1, 2, and 3 family metabolizing enzymes. Nearly 80% of clinical drugs used in common practice are metabolized through them, which is an opportunity for high impact if we have those pharmacogenomic results available. Next slide. Now, in terms of cost effectiveness, this is one of the harder things to articulate and argue when we're talking about practice expansion. The first reason for that is, what is the actual cost of the pharmacogenomic test and the pharmacogenomic panel? Well, what we know is that a panel of pharmacogenomic tests where we're testing multiple of them is more cost effective than doing individual targeted genes and tends to have better overall results in terms of optimizing a comprehensive medication regimen versus one at a time. There's been numerous meta-analyses that have looked at cost effectiveness, and I've shared one example from the Pharmacogenomics Journal with you today on this slide here. I thought this was an interesting example because it's a meta-analysis of 44 different economic evaluations for 10 different drugs. And what they did is they looked at the cost difference between cost with pharmacogenomic-driven dosing versus cost with standards of care, and compared that to quality-adjusted life years, and then added in a factor of a willingness to pay, with the argument being that if you have superior cost and it exceeds a certain threshold, people will be willing to pay for that added value from the pharmacogenomics tests. And what they found when they integrated all of these different economic evaluations were that 30% of tests were cost effective and 27% were dominant or cost savings, meaning that we saved cost and we demonstrated superior efficacy in terms of that quality adjusted years of life. Now, on the right-hand side here, the top version of this plot looks at the different breakdown of those groups, part A, and then the authors went on to argue that as time goes on, we're going to have less and less cost associated with the pharmacogenomics test. We're going to be more efficient, we're going to standardize things, labs will be cheaper, and as that cost approaches zero, they adjusted that analysis and found even more cost savings and efficacy increases when you had pharmacogenomic-driven testing, which gives us hope for a future when we don't have to worry as much about the cost of genomic tests. Next slide, please.
So having this in mind, seeing some of the cost effectiveness of these panels and this testing, as well as some of the initial evidence that was coming out, at Mayo Clinic, they started the Write 10K or Write 10,000 project. And this was a study of over 10,000 participants that were being cared for at Mayo Clinic. And they sought to sequence 77 different pharmacogenes from these participants. And initially, this resulted in 13 drug response related phenotypes that ended up being placed into our electronic health record based on the panel that we had developed at the time for the purposes of this study. And initially, at the time of the publication of our initial results, initially we had 21 drug gene pair alerts that were present in our electronic health record, but that number has certainly grown over time as we do more testing and have more updates to our record. And the main talking point to make sure we think about is, as you're trying to implement this at your own facility, have the discussions of what type of panel, how many genes you want to include on your panel. It was the team's decision at the time for Mayo Clinic to use a 13 gene panel, but you can have the discussion of what would be most applicable and important for your practice site or practice setting.
I'm going to add a few more details to talk about our journey. So we started with that Write 10K project and having infrastructure available. Now, we were very lucky in that some of the physicians on our transplant team were part of pharmacogenomic testing and applying it to other practices besides transplant. And so there was already a lot of enthusiasm and some buy-in already from our physician group stakeholders as we sought to incorporate this into practice. The next step was to get patients to buy in. So making sure that we are communicating clearly what the test is, what it is and is not testing, how we're going to be using genetic results given the sensitivity of that information, and working with them to understand where we should be testing them and why we're going to be using those results. Then, as Dr. Milton alluded to, we had to figure out what tests we were actually going to run. So when you look at commercially available pharmacogenomic panels, there's numerous of them. A lot of them have overlapping enzymes that they're testing phenotypes for, but not all of them are comprehensive. They have specific ones some tests include and others don't. And so when you're thinking about applying this to your practice and you're shopping for those panels to use for your lab, you'll want to look at what the results are and make sure that reflects the medications that you're commonly using in practice. For example, in transplant, we would for sure want a pharmacogenomic panel that included TPMT because we sometimes use azathioprine as one of our immunosuppression agents. The next step was designing a workflow. So figuring out who is going to be ordering the pharmacogenomic test, at what point in the transplant journey are they going to be ordering this test, who's going to be receiving the results and interpreting those results, how are they going to be communicated, and who is going to be taking ownership of making dose recommendations actionable or making the changes that are recommended. Next, we built order sets and panels so that we were making it easier for all of our prescribers to order the correct pharmacogenomic tests. And that included consultations that go to the pharmacist in order to be able to be alerted to the results that are available and make clinical assessments with consultations. And then we entered a pilot phase for a few years where we decided we're going to do this on all of our patients that we can. Let's see what we do with the information once it's available and tease out any types of errors or bumps in the road or obstacles that we encounter along the way, because you can't anticipate everything. After doing that for a few years, we discovered that only 10% of our patients actually had pharmacogenomic panels at the time of transplant. And so we initiated a robust quality assessment with targeted education, looking at what adjustments do we need to make to the workflow in order to get more of these tests available? Are people actually using the results? And if not, why not? And getting some of that education points, both in terms of how the operations fit together, how we're counseling patients, and how we are going to be using and where to find the information in the medical record to reference so that we're all on the same page and we're using this information collectively. Next slide, please. Now, in terms of addressing the barrier of using pharmacogenomic information, some of this Dr. Milton has talked about, but we're just going to double down here to list the resources that we created for our practice. The first thing was to endorse resources for interpretation. What are the point of care references that we can go to in order to get answers of what each of these results mean? So we have Ask Mayo Expert, which is a similar tool with point of care resources that contains pharmacogenomic specific recommendations and is edited regularly by experts within the field and available to us. There's also ClinPGX, formerly PharmGKB, which is my go-to reference where you can type in a medication name. Sometimes it has the options of selecting genotypes and phenotypes to see what types of prescribing recommendations are available from the various guidelines available. There's always the Clinical Pharmacogenomics Implementation Consortium guidelines, along with the Dutch Pharmacogenomics Workgroup guidelines and other types of references like that. In terms of using the results and creating clinical decision support, one of the things that our institution did that I'm super pleased with is they created a banner within the electronic medical record for all pharmacists on the side of the screen that announces that there's pharmacogenomic results available for the patient. That way, when you're going about verifying or looking at a new prescription for a patient, you can easily see that they have genomic information available that might relate to the drug you're evaluating, and you can link directly there into what the pharmacogenomic panel results were for using in your assessment. Easily available all in one place with minimal clicks. We also invested in creating alerts at the point of prescribing with interpretive guidance and linked resources for medications that had major pharmacogenomic associated actions or recommendations, for example, abacavir. And then next, our institution worked to create a Mayo Genomics application navigator within the electronic medical record. Essentially, what that navigator does is it summarizes what clinically significant phenotypes resulted from those pharmacogenomic panels. And then below it, if there's medications that are currently prescribed that have actionable pharmacogenomic results, they'll be linked there and you can look into the resources with recommendations built within the system. I want to acknowledge the fact that one of the things that has made us most successful in terms of implementing pharmacogenomic recommendations into clinical practice is the investment our pharmacy department has made in terms of training pharmacists to use this information. On orientation, all of us are given the opportunity to do 16 plus hours of continuing education credits, specifically targeted at learning about the pharmacogenomic applications and clinical resources available. And so all of the pharmacists involved in our transplant patients' care have some level of familiarity with how to use these results, how to resolve questions, and how to optimize medication regimens with them. Lastly, because a lot of recommendations from these guidelines and point of care resources can sometimes be nonspecific, for example, recommending monitoring for efficacy, we found that there was some gaps in terms of consistency of recommendations between pharmacist to pharmacist. We know this with common dosing of other medications, especially renal function, that sometimes people differ in terms of what they assess is needed for action. And so what we did is we created a transplant-specific practice resources, looking at all of the data available with commonly prescribed medications and saying, when we see this result, if these factors are present, this is what we recommend as a group. And reviewing those together, debating together, and coming to a reasonable consensus of how we'd use the information. Next slide, please. One of the things that I want to make sure is emphasized is that pharmacogenomics offers the opportunity to be proactive versus the standard of care being reactive in terms of seeing medication-related adverse effects and then adjusting dosing versus predicting there could be a possibility of an adverse effect or ineffectiveness and adjusting proactively. The value in pharmacogenomic testing is making those bold and anticipatory adjustments to medications to prevent those events from occurring. If we're getting the genomics results and we're just saying we're going to monitor and wait for those types of events, we're really not going to see the benefits in terms of improving quality of care. Next slide, please. So, what does our workflow look like? Well, first, we start with testing patients during their transplant evaluation phase. This is for a few different reasons. The biggest one is to have the pharmacogenomic results available at the time of transplant so that we can act on them when most of those medication changes are happening. And the other nice piece about incorporating it into the evaluation phase is we can include that cost of the genomic test into the evaluation bundle for reimbursement. So it doesn't tend to be as big of a deal with our practice. Next, we wanted to incorporate a pharmacogenomics consultation. So with our test ordering, we always include a test for a pharmacogenomic evaluation from a pharmacist. We know that during the evaluation phase, not all of the patients being evaluated for transplant are going to be able to proceed to transplantation. However, if they have a pharmacogenomic panel that is part of the evaluation, we felt a duty to have somebody looking at that, assessing it, and giving them some optimization opportunities or recommendations to take that back to their primary care team. And having that pharmacogenomic consultation built in there ensured that every patient that gets these tests performed has that optimization opportunity and is going to benefit from the results, whether or not they get put on the transplant wait list. The next phase would be heart or lung transplant. So this workflow is specifically to our heart and lung transplant patients. We don't routinely do the pharmacogenomic panels in our abdominal transplants. But at the time of transplant, our pharmacists are looking at the pharmacogenomic panel, looking at all of the new data that has happened since that evaluation phase and the initial consultation, and putting a new consult note into the chart with plans for how to adjust current medications, what things need to be monitored and optimized, and making a very big effort to be transparent with our multidisciplinary team to show them how we're using these results in clinical practice and how they can be relevant. And then finally, looking at longitudinal care. So we have best practice alerts built into Epic for numerous different medications, but we needed to make sure that we're routinely referencing these pharmacogenomic results. And to do that, we had to share with our team what resources we're looking at, how to access that information, how to respond to questions relating to new medications, and really encourage our providers when they're getting alerts relating to things that or medications they're prescribing relating to the genomics panel, making sure they know that we're available as a a ready resource to offer some expertise in navigating should they need help. The goal is to use those pharmacogenomic results at the time of transplantation for the best impact. All right, next slide. Now, during that evaluation phase, one of the questions I commonly get from colleagues is, how are you talking to patients and introducing the pharmacogenomic test to them? This is part of that stakeholder buy-in. So step one, I've outlined a few different conversational points during that evaluation phase that I like to talk through with our patients. I first introduce the pharmacogenomic panels by just telling the patient everyone responds to medications differently. Generally, when you say that, they have a story or an anecdote relating something that they experienced or someone in their family or close proximity has experienced relating to an adverse effect related to a medication. Then we talk about how DNA tells us how the body processes medications, introducing that idea that it gives us a code for how we're producing those drug metabolizing enzymes and how it gets rid of medications and affects their overall exposure. Then we look at how results will help us pick the right medication and dose for you. I just simply state that. These results will be used to pick the right medication for you and help us choose the right dose for you. And then explain to them that the goal is to really prevent those adverse effects and optimize effectiveness of their medication regimen after transplant. And I clearly state at that time that this pharmacogenomic test is relevant to transplant medications, but can really be used to all of the medications on their list going forward. And they won't need to repeat that test frequently in the future. The results will always be relevant. Next slide, please. So now we want to transition and talking about the clinically significant drugs and genes that we routinely evaluate. And with that, I'll transition over to Dr. Melton.
So as Dr. Lemke was mentioning in our workflow, when we get the pharmacogenomics consultation, our goal is to try and create some kind of reference for the providers and for our teams moving forward to have to look to in case there's new drugs that pop up or new considerations that need to be made. And primarily we do this in the form of a note in our electronic health record, and then we'll carry these recommendations into our rounding situations or just with clinical discussions. And common groups that we will run across that have pharmacogenetically important or significant interactions and considerations include our immunosuppression, antimicrobials, pain management, some psychiatric medications, anticoagulations, statins, and then we'll also just start to include relevant past medication history for assessment of intolerance or otherwise into our consultations. And these are just some main things that we'll try to document in a single note that could be used as a reference for longitudinal care, as Dr. Lemke also kind of mentioned already.
Now, this slide is a little busy, but not meant to overwhelm. Dr. Melton highlighted the drug classes that have commonly associated medications with higher impact or we encounter more frequently on our transplant services. This is a slide I composed talking about therapeutic classes and drug gene pairs that have actionable pharmacogenomic recommendations available that I use to share with our physician stakeholders to illustrate the helpfulness of having these panels available. It's amazing what type of gain and buy-in you'll get when they see medications like proton pump inhibitors or ondansetron, or even tacrolimus or voriconazole, things that they're commonly prescribing or seeing in clinical practice that have actionable items and recommendations available. Next slide, please. Now, we want to start focusing on our immunosuppression drugs and some of the data behind using pharmacogenomics with their use. And with that, I'll start by talking about tacrolimus. So CPIC guidelines have recommendations for tacrolimus that essentially break down into if you have a patient with a CYP3A5 star 3 or poor metabolizer status, this is going to reflect the majority of the population that we transplant. The standard dose of 0.15 milligrams per kilogram per day that they estimate is their recommended dosing. When you have intermediate to normal metabolizers of CYP3A5, those with 1 or 2 star 1 alleles, you're going to increase, they recommend increasing the dose to 1.5 to 2 times the standard dosing interval. Now, this graphic is from Burnett and colleagues that look at the therapeutic drug monitoring of tacrolimus with recommendations. And they looked at the entirety of evidence available for pharmacogenomics and offered an additional consideration where we look at CYP3A5 phenotype and genotypes in addition to CYP3A4, specifically CYP3A4 star 22. What they found is that when you have a patient with CYP3A4 star 22 allele, those patients required about 33% lower doses of tacrolimus, irrespective of their CYP3A5 genotype. So really combining the two is best practice for coming with more precise dosing using all of the genomic information we have available. And with that, in the second row on the table, they include dosing advice, where the poor metabolizers for both star 3, CYP3A5 star 3, and CYP3A4 star 22, who are going to be the most sensitive to tacrolimus, have a lower starting dose of 0.14 milligram per kilogram per day. And then those intermediate metabolizers, normal CYP3A4 phenotype, having 0.2 to 0.25 milligrams per kilogram per day. And then those with the CYP3A5 star 1 and CYP3A4 star 1, those that are normal metabolizers of CYP3A5, having the highest dose recommendations, where we're looking at 0.3 to 0.4 milligrams per kilogram per day. Of course, these dosing recommendations should be modified with consideration to the organ being transplanted and institutional dosing practices, but nevertheless give us some insights on how we would adjust tacrolimus dosing when pharmacogenomic information is available. Next slide, please. Now, one of the things we want to look at is there any evidence for using our pharmacogenomic information-based dosing versus our standard of care weight-based dosing for tacrolimus? This is a randomized controlled clinical trial from back in 2016 that looked at that very question. They recruited 244 living donor kidney transplant recipients, and they looked at when you started the two different dosing regimens based off of the pharmacogenomic information and then a standard weight-based dosing, and looked at what the first tacrolimus level was at steady state, so 3 days later. Was there a difference in patients achieving their goal tacrolimus level? And when they looked at the time point, they saw no difference between standard dosing group and the genotype-based dosing group. Additionally, the number of dose modifications to achieve their desired goal, the time to achieve their desired goal, and clinical outcomes showed no difference between the two groups. So discouraging information, and kind of led us as readers the question of, is it worth even having this information available for tacrolimus if we're not going to see a difference between the two different dosing regimens? Next slide, please. Now, addressing this, there's a really helpful review and meta-analysis from Therapeutic Drug Monitoring published in February this year that looked at cumulative evidence of pharmacogenomic testing or pharmacogenomic dosing of tacrolimus across a series of randomized controlled clinical trials. The table illustrated on the right is a summary of the major clinical trials that they focused a lot of their text on. What they conclude is that incorporating CYP3A4 and CYP3A5 into dosing strategies can reduce the time to therapeutic levels and the number of dose adjustments required. One of the things I thought was insightful from this review is that they emphasize that Bayesian dosing strategies, where we're individualizing dosing using variables beyond just weight, tended to have better outcomes in terms of getting more precise dosing and getting into therapeutic goal range without going over or under unnecessarily. What this really told me is that when we're comparing genomic guiding dosing to standard of care dosing, because weight-based dosing in itself is a poor predictor of overall tacrolimus exposure, we have a lot more variables that affect it. When we're comparing the two different recommendations and it's using that weight-based dosing as a resulting recommendation, you're not really going to see superior results if you have an inferior mechanism of dosing the tacrolimus. So incorporating those other factors is key to getting that precise and good results in terms of optimizing overall tacrolimus dosing. Next slide, please. Now, this is a study that was looking at tacrolimus variability and rejection risk when we're accounting for pharmacogenomic information. The authors included 1,200 European American ancestry patients and compared them to 246 African ancestry patients that had CYP3A5 genotype information available. Figure 2 is a survival curve that broke down between the different groups with 0 loss of function alleles, which are normal metabolizers, 1 loss of function alleles, which are intermediate metabolizers, and 2 loss of function alleles, which are poor metabolizers, the majority of patients in that final group, and looking to see if there was a difference in rejection-free survival. As you can see from the figure A on the top, is that in African ancestry patients, those that had, no, I am, yes. Those that had African ancestry and had CYP3A5 star 1 alleles tended to have lower rates of rejection-free survival. And when they looked at the European ancestry cohort, they saw no big difference between the different groups. But in that figure, the figure B there, you'll note that the star 1 allele type was only present in 6 of those 1,200 plus patients. And so you can't really draw conclusions from that. Overall, the authors concluded that after they controlled for variability in tacrolimus dose in each loss of function allele, there was 84% lowered hazard ratio of acute rejection. Next slide, please. Now, this was another fun study that looked specifically at pediatric heart and kidney transplant recipients and their CYP3A5 genotypes in terms of expressors having at least 1 star 1 allele versus non-expressors or poor metabolizers, and seeing if there was a difference in time and therapeutic range of tacrolimus. What they found in the figure on the left is that there was a statistically significant difference in terms of time and therapeutic range between expressors and non-expressors, with expressors having a lower time and therapeutic range within the first 90 days of transplant, but that effect tended to level off as you increase time from transplant within the full year after transplant. That makes sense if we're using therapeutic drug monitoring. Eventually, we're going to get an idea of what patients' dose requirements need. We'll have less fluctuation in that dose because we're at a more stable medication dose. On the right-hand side, they looked at frequency of rejection and donor-derived cell-free DNA-free and looked at the non-expressors and expressors and divided them into time and therapeutic range that was less than 35% and greater than 35%, with figure A being between 0 and 90 days post-transplant and figure B being between time 0 and 365 days post-transplant in terms of the overall time and therapeutic range. What they found was that those that expressed CYP3A5 star 1, irregardless of time and therapeutic range, had a lower rate of rejection and donor-derived cell-free DNA survival compared to the non-expressors. So potentially giving us an indicator that these patients would be at higher risk of rejection. Next slide, please. The last thing I wanted to point out is the CYP3A5 has been evaluated looking at calcineurin inhibitor toxicity, specifically tacrolimus calcineurin inhibitor nephrotoxicity. The study by Kuipers included 304 kidney transplant recipients, and they looked at different biopsy results over time to specifically detect calcineurin inhibitor-associated nephrotoxicity. They divided the patients by their overall tacrolimus dosing requirements, those with less than 0.1 milligram per kilogram per day, 0.1 to 0.2, and then greater than 0.2 milligram per kilogram per day, and found, not surprisingly, that folks with higher tacrolimus dosing requirements tended to have higher rates of calcineurin inhibitor nephrotoxicity. And when they looked at genomic information available, the CYP3A5 star 1 genotype and continuation of steroid therapy were independently associated with development of biopsy-proven nephrotoxicity. So we have indicators that the genotype could possibly be associated with rejection and medication toxicity. Does that mean we don't use tacrolimus in folks that have CYP3A5 star 1? No, but perhaps it's a marker that we can look at those patients a little bit more closely with monitoring in order to optimize their post-transplant cares. I'll turn it over to Dr. Melton.
Thank you, Dr. Lemke. So after the focus on tacrolimus, we'll start focusing on some of our anti-metabolite medications. The first one focusing on azathioprine and relative pharmacogenomic considerations that we would use in practice. So the two enzymes that help with metabolism of azathioprine that we're going to focus on are the TPMT or pardon me, or thiopurine methyltransferase and NUDT15 or Nudex hydroxylase 15. And here is just a table of the summarization from the CPIC guidance, taking both of these enzymes into consideration. So if either of these are poor metabolizers, we would really want to just consider alternative therapies if that is an option for this patient. And then if either or both are considered intermediate metabolizers, then adjusting the starting dose anywhere from 20 to 50% if it's both, or 30 to 80% of the target dose if only one of them is an intermediate metabolizer. And then only in the case of both of them being considered normal metabolizers would we consider starting at a target dose. And an interesting point to think about as we incorporate this into clinical practice is differentiating for TPMT, the genomics versus activity assays. So genomic assays, the main part being that these are stable tests that your genomics don't change, and it's a good predictor of where to start with these therapies, as opposed to the activity assay, which is going to show, yes, how active the enzyme currently is, but that is influenced by many other factors, which includes patient's gender, their smoking status, their age, and exposure to other medications. And this could be, if it's thiopurine exposure, possible induction of the enzymes and increased activity, or inhibition by other medications. So if we're looking at an activity assay, it may not give us predictive, as much predictive power at baseline compared to the genomics. So just to make sure we know what we're looking at between the two different test types. With that, I will hand it to Dr. Lemke to focus on mycophenolate.
So we know in clinical practice that there's great variability in terms of mycophenolate tolerance by our patients. Lots of side effects. When we do kinetic studies and look at drug levels, great amounts of variability between patients in terms of what those overall exposure to mycophenolate is based off of the dose. With that, it's been one of those medications that we've tried to look to see if pharmacogenomics could help us better understand some of that variability. Now, one of the things that makes it very difficult to draw pharmacogenomic recommendations for mycophenolate is the fact that it has very complex pharmacokinetics. I've included a metabolism and pharmacodynamic pathway drawn from the PGX database on mycophenolate, and you can see that there's layers of complexity involving multiple drug transporters, metabolizers, and then also in terms of its overall enterohepatic recycling and getting reused back in the system. Complicating it further, there's numerous drug interactions and other factors that play into absorption and ability to process and move through this pathway. So overall, we haven't seen a ton of single pharmacogenomic results that have helped us make an actual recommendation for these patients that has been consistent with drug exposure and clinical outcomes. I've listed possible genes of significance that have been explored. For example, UGT1A9 is responsible for biotransformation of mycophenolic acid into mycophenolic acid glucuronide. ABCC2 is a drug transporting protein that helps it eliminate mycophenolic acid glucuronide into the bile. And then IMPDH2 is relating to its actual mechanism of action, looking at pharmacodynamic interaction there, seeing if folks that have different polymorphisms end up having different responses to the medication dose overall. And one of the things that I find most fascinating is there actually is one pharmacogenomic related recommendation for mycophenolate which has to do with that HPRT and hereditary deficiencies, in that if patients have a disease state or demonstrated deficiency of that HPRT, they're generally at high risk for uric acid accumulation and associated toxicities when on mycophenolate. And that's included in the package insert with a screenshot below. Next slide, please. All right, let's talk about application into clinical practice. Dr. Milton.
So now we've kind of laid the groundwork of different considerations that we'll have, different experiences in literature of different evidence that we have so far. This is the approach that our team takes when we're trying to navigate drug interactions and pharmacogenomics in our practice with our patients. So kind of starting from the top, just working to note clinically significant phenotypes that could be present with our patients. So in this example, looking at 2B6, 2D6, and 3A5. And then from there, identifying what drug metabolizing enzymes would be important for a drug-gene interaction. So if we take the example of tacrolimus and 3A5, so we have that metabolism picture from ClinPGX, similar to the last pathway on the right-hand side, kind of highlighting where our 3A5 enzymes are on the right. And then we can look further for inducers and inhibitors. So for the example of phenytoin, the induction leading to incorporation of more 3A4 and 3A5 enzymes that would increase the metabolism and therefore decrease tacrolimus levels. And on the other side, we have inhibitors like itraconazole, blocking that metabolism at 3A4, and then and then increasing tacrolimus levels. And overall, we really need to consider just what the net effect in clinical significance would be. So this is where therapeutic drug monitoring, as we've touched on throughout the presentation, is important, not just because it gives us our goals and our ranges, but it helps us to assess in these patients that might have a genomic variability and inducers or inhibitors. There can be an increased fluctuations in interpatient variability, and trying to capture those points and make sure we keep them at therapeutic ranges when it could be more difficult than a standard approach patient. And a secondary consideration to always have is phenoconversion. And an example we like to use is the use of bupropion in the setting of somebody with CYP2D6 intermediate metabolizers. They can effectively become a 2D6 poor metabolizer. And then this has impacts on interactions with other medications that should be considered. One for us is with pain management, a consideration that could be made if there are other drug interactions present. Now I'll hand it off to Dr. Lemke to apply this to Jonathan.
So back to Jonathan. So walking through our stepwise process for incorporating pharmacogenomic information, we'll start with noting clinically significant phenotypes. So from his panel, I've listed them there. The most clinically significant one for his transplant regimen would be that CYP3A5 normal phenotype. Next, we're going to look for drug metabolizing enzymes. And so I listed the different transplant medications and their relevant drug metabolizing enzymes, and then highlighted tacrolimus since it's the only one with a clinically significant result that would affect medication dosing. Next step is we're going to look for inducers and inhibitors, and he's being started on posaconazole for antifungal prophylaxis after lung transplant, which is going to affect our tacrolimus dosing. And now we need to consider the net clinical effect and significance. So because we know he's a CYP3A5 normal metabolizer, we know he's going to require much more tacrolimus compared to your average patient that is a poor metabolizer, up to a twofold or higher different increase in overall exposure. But the question would be, how do we navigate that with posaconazole on board? Well, there's two different schools of thought. The standard dosing practice would be to look at that 0.15 milligram per kilogram per day, multiply it by his weight, say 75 kilograms, and you'd get 11 milligrams per day as the recommended starting dose. From there, drug interaction guidance would tell us to reduce the dose to 1/3 of that to account for the posaconazole. And so you'd prescribe this patient 3.75 milligrams per day or 3.5 milligrams per day. Now, if you incorporate the pharmacogenomics information, you would start with something more like 0.3 to 0.4 milligrams per kilogram per day, multiply it by 75. That gives you about 30 milligrams per day of tacrolimus. 1/3 of that would be 10 milligrams per day. And so you can see there's a big difference there in terms of what you would anticipate the patient to be on. One being 3.5 milligrams per day, the other being 10 milligrams per day. Now, are we going to start him off on 10 milligrams per day initially post-transplant? Likely not. It would really depend on his course. What induction did he get? What's his risk of rejection? Do we have time to get to therapeutic goal? Did he have a kidney injury after transplant? We know tacrolimus is nephrotoxic, so maybe we wouldn't start with that dose. But knowing where we're going to end up and how much the patient will ultimately require gives us a nice map and to create a thoughtful journey of how we're going to manage that tacrolimus initially post-transplant to account for all of those things. I'll hand it back over to Dr. Melton to talk about some data from our practice.
Thank you, Dr. Lemke. So after we're going through our thought process, we've implemented this practice with our solid organ transplant patients on heart-lung transplant. And the data I'm about to review is coming from January 12th to May 7th of this year, covering 29 thoracic transplant patients during that window. So in these 29 consults, we commonly saw 2 to 3 clinically significant results within our patients. And only one patient had no clinically significant pharmacogenomic results on the panel that we had selected for. And looking at just some of the more common drugs that we would interact with or the groups of medications, we see here our most common adjustments will come in the way of considerations for statins, pain management, and then depression or anxiety medications. And to focus more on those depression and anxiety medications, there could be commentary from us on the increased risk of toxicity or even therapy failure, depending on where their genomics phenotypes are landing. And then whether or not to involve transplant psychiatry post-transplant to help guide ongoing therapies if they're more complicated. And then we also have noted here a significant amount of monitoring for classes such as PPIs, again, pain management, and then the depression and anxiety medications. On a different approach, on the other side of this, we can look at the observed phenotypes that we have in our patients. So CYP3A5, just to hone in on something that's important to all of us very much, was predominantly poor metabolizers, which would make sense. And then the most common phenotype otherwise were predominantly normal phenotypes across our groups for groups like 2B6, 2D6, and 2C19. And roughly overall variability kind of matches what we see in the population, but this is helpful to know when we're making recommendations precisely where our patients lie, as Dr. Lemke was saying, to be proactive and not reactive to a lot of these therapies. And then in terms of just longitudinal approaches, things we're trying to look at is how these recommendations are getting incorporated long-term. So that could be things of surveying physicians and pharmacists on how they have incorporated this data into longer-term therapies. When different flags pop up when a drug gene pair interaction is noticed on Epic with a new therapy being ordered and how those are being interacted, and just what recommendations our pharmacists are making based on this data is what we're planning to do from a long-term perspective. With that, I'll hand it to Dr. Lemke for some final thoughts.
Yeah, so to conclude our presentation, pharmacogenomics is one piece of the clinical picture. It's helpful for helping us guide dosing, but we need to consider all of the other factors incorporated into the patient's care to monitor and clinical response and make optimization recommendations. Transplant recipients are at high risk of adverse drug events, which I think is the big reason why pharmacogenomics can be beneficial for them. And tacrolimus associated with significant intrapatient variability. CYP3A5 metabolism is an excellent tool to predict dose requirements and can help us identify patients at risk of rejection and tacrolimus-associated adverse effects. And tacrolimus dosing guiding by pharmacogenomics decreases time to therapeutic level generally, increases time in therapeutic range post-transplant, and may reduce the number of dose adjustments and monitoring required to stay within the goal range. And then the helpfulness of azathioprine is well established with Dr. Moulton's prior slide. So with that, we'd like to thank you all for your time today and take any questions that the audience might have for us.
Thank you so much, Dr. Lemke and Dr. Melton, for a wonderful talk. I apologize I was late coming into the talk. I wanted to just send an announcement to everybody that this webinar is approved for 1 hour of ACPE credit. So after the webinar, you will receive an email with the link to obtain your credit. And today's webinar is also going to be posted on the ACCP Transplant YouTube channel. So again, I just want to thank Dr. Lemke and Dr. Melton. If we could, wish we were live, we could give you a nice round of applause. Does anybody have any questions? I don't see any questions in the chat, but if you want to feel free and unmute yourself and go ahead and ask a question. Mabuba Ahmadi, go ahead. I see your hand up. Do you want to go ahead and unmute yourself? Well, could I ask a question while we're waiting for Dr. Amadi to unmute
Yeah,
themselves?
please.
You guys give quite a bit of information about lots of different drug gene pairs. And I'm assuming at Mayo you have a whole pharmacogenomics program, is that right?
We do. We have pharmacists specializing in pharmacogenomics specifically in addition to our group.
That's wonderful. So could you maybe give us, and I apologize if you talked about this at the beginning, but what is your sort of process? So, and I'm thinking in particular, if you've got a patient with multiple drug gene polymorphisms, where you've got 3A5 and maybe you have NUD15 and maybe you have 2C19 that you have to take into account. Is there one pharmacist who sort of gives the full consult, or does the transplant pharmacist talk about the tacrolimus and CYP3A5, and maybe the pain pharmacist talks about 2D6, or how does all of that workflow work?
Generally, the pharmacogenomics pharmacist and us both comprehensively evaluate the entire medication regimen. The genomics pharmacists are consulted in that transplant evaluation phase when the results are initially available. And then once they come in for transplant and have an entirely different medication list, the transplant pharmacists are taking ownership of that comprehensive review. And typically, if we see someone that has multiple different clinically significant phenotypes, and I can't, say confidently what to do with whatever pickles in front of me, I have a low threshold to reach out to folks and gather some other opinions, which I think is one of the wonderful parts of being a pharmacist. Is there's always a instant messenger bat line where you can find an expert to chat with.
Yeah, that's wonderful. And I love the study that you're doing, and I can't wait to see the results of some of um, you know, the clinical outcomes of some of those patients that have all of those different polymorphisms. And I guess just one more sort of, taking a big step back kind of question. So if, many institutions, including ours at UCSD, Tanner knows, we don't have a pharmacogenomics integrated program. How would you suggest somebody start out? Like at Mayo, did you start out with one drug gene pair? Or did you end up starting out with a full comprehensive, panel of genes? What's your advice?
We've changed approaches. I think in terms of cost effectiveness, getting a panel is going to be the best bang for your buck in terms of knowledge gained. That said, a lot of times on these panels, they have drug gene pairs that are never going to be relevant to the patient. Like, for example, a lot of oncology meds are on our pharmacogenomic panel. And I get a lot of questions from patients about how to interpret that information. And I usually just tell them it's kind of like bulk buying at Costco. We know if we put all of these things together, we get a better cost effectiveness in terms of results. And that they do is they're making a lab test that's relevant to the most patients possible. So you might not have anything that's relevant in those types of drugs, but instead just focus in on the ones that are relevant to transplant. And that's what we kind of have done. I think in terms of like physician buy-in and advanced practice provider buy-in, taking things that are simple, like your routine medicines, the pantoprazole, for example, as soon as we told them that that had pharmacogenomic significant results in addition to the tacrolimus, there was piqued interest. One of the things we deal with is patients with wildly uncontrolled heartburn after transplant. This could help us proactively resolve that. Making the simple steps, starting with your basics and picking a good panel. And, if there's ones that you're not as familiar with, you can always learn a little bit later.
Wonderful. I do see a couple more questions. So, how do you handle ensuring insurance coverage prior to the pharmacogenomics being drawn? At what point of the evaluation process are you having patients get the test done, assuming you want to be sure patients will likely proceed to transplant first versus being deemed not a candidate?
Yeah, so we're getting the test done with the other evaluation labs in that pre-transplant phase. In terms of insurance coverage for the genomics test, I'll be 100% transparent with you. I have not seen a huge issue with it in our patient population. Um, I'm not always privy to the billing end of things and when stuff gets rejected, but I haven't actually heard a direct complaint from patients either. I do know that from the pharmacogenomics specific pharmacist group, that there has been situations where insurance coverage has been an issue, or they'll cover one or a few things on a panel, not the whole panel. And that gets a little bit hard to navigate, but I'm thankful that we've built it into the pre-transplant evaluation bundle to kind of not sidestep, but for thoughtfully including it along other different standard of care labs that we consider in that bundle.
Great. And then maybe we have time for just this one last question. So first of all, both of the participants said great presentation, excellent presentation. So in addition to the evidence showing that 3A5, 3A4 testing can help patients reach therapeutic tacrolimus levels with fewer dose adjustments, are there studies that also show an impact on outcomes like acute rejection or drug-related side effects? For other drug gene pairs, those kinds of clinical outcomes are often used to support routine testing. And the participants asking because they're looking at implementing this, and some providers may not see as much value if the focus is only on dose optimization versus clear patient benefits.
I think I would guide this audience member to the slide that we covered relating to the meta-analysis on cost effectiveness. Tanner, would you mind taking the question? I'm getting booted out of my room.
Oh, sure. Yeah, I can move this back really quick. I'll just stop with
So yeah, I kind of remember you had a nice slide that summarized a series of studies, and it was a meta-analysis because there was that one study that didn't show any clinical benefits, but then I believe in the meta-analysis there was some clinical benefit to the 3A5 testing. Is that right, Tanner?
Yes, and that is I'm almost back. It was very early on in our presentation, so I'll do current slide.
I would say it's all in about how you do that cost effectiveness study or analysis. So, these are hard things because you don't have clear clinical outcomes always associated that are common across all of the different medication classes. But using that meta-analysis and taking the perspective of quality adjusted life years and looking at patient desired outcomes from that and those individual drugs and quantifying them in that way, you do see overall they're cost effective and sometimes cost dominant for the variety of drugs tested. In terms of specifics, can chat more offline, but I would really go to those meta-analysis because there's numerous ones out there that demonstrate over and over again cost effectiveness in terms of both medication dosing and accounting for clinical outcomes. Though I will say that capturing those outcomes is a little bit more difficult in the literature.
Great. And I believe it was in TDM 2025. Was that right, Dr. Lemke, the meta-analysis?
I was thinking the one in Pharmacogenomics 2020 or 2017 here.
Okay.
That Tanner's showing.
Okay, wonderful. All right, well, we're about 7 minutes past the hour, so I think we will close this session. And thank you so much again, Dr. Lemke and Dr. Melton, for a wonderful presentation.
Thank you all for your time. Appreciate it.